Welcome everyone to today's webinar, and thank you for attending. My name is Nicole Kennedy, and today we're going to take a deeper dive into the Promoting Interoperability category for MIPS and Medicaid Meaningful Use. If you all are on the phone line, if you would just please mute your phone as we get going here, that way, and then you can unmute at the end so we can open up for questions. All right, today's webinar goals, we're going to spend some time discussing both the MIPS and Medicaid Meaningful Use program, since there are a number of providers who are still eligible for incentive money through Medicaid Meaningful Use. We're going to discuss each objective and measure and provide some helpful tips and leave some time at the end for questions and discussions. I'll start today with MIPS. As many of you already know, there are 4 categories to MIPS this year. Today's presentation will focus on one, the Promoting Interoperability category, or PI. Though the category weight remains 25% of the overall composite score, just as in program year 2018, providers will find it significantly more difficult to achieve the full 25 points. In 2017 and 18, the scoring methodology of base measures plus performance measures, along with opportunities to earn bonus points, made it very likely that many of you achieved the full 25 points for the category. But this is not the case in 2019, as I'll be explaining. Why is it important? The payment adjustment increased to an astonishing 7% this year. That means that an eligible professional failing to report stands to lose 7% of all of their Medicare Part B reimbursement. A provider that, say, just meets the threshold and bills $100,000 per year to Medicare Part B could stand to lose $7,000 in 2021 for failing to participate. As you can see in this diagram, a minimum score of 30 is required for a neutral payment adjustment, but those reporting greater than 75 this year stand to increase their reimbursement by several percent. Since the scoring is performance-based, it is essential that you perform to the highest level in each category. Shifting now to the Medicaid Meaningful Use, the why here for eligible professionals is related to the remaining incentive dollars in the Meaningful Use program. Providers that were able to AIU or adopt, implement, and upgrade as late as 2016 have until 2021 to attest for the full amount that the program offered. But this means that you also must finally report for the dreaded stage 3. Now rather than later, that's the key. If you're unsure about your status for MIPS 2019, make sure that you consult the QPP. Determine now your level of participation. Are you going to report as an individual or a group? And verify that you've assigned a security officer role in the QPP or HART website for your practice. For Meaningful Use, identify those providers in your practice that are still eligible to attest. Demonstrate that you have the minimum amount of Medicaid volume, and verify your NCID and NPPES usernames and passwords. Important to note, now's the time to verify your EHR. Are you a 2015 cert? If not, schedule your necessary upgrades. Each program, MIPS and Meaningful Use, require a minimum of 90 continuous days for the reporting. And each program requires that you complete your Security Risk Assessment, or SRA. All right, so let's start with some of the overlapping measures. First, we're going to look at e-prescribing. You must generate and transmit permissible prescriptions electronically, just as in years past. But for MIPS this year, this is worth 10 points. And for the Medicaid Meaningful Use program, it's 60% rather than 50% as in last year. It's also important to note that all Schedule II or Schedule III controlled substances must be e-prescribed by January 1st of 2020, according to the North Carolina STOP Act. If you are unsure if your system is currently e-prescribing controlled substances, you'll want to check with your vendor on this. Next, we look at the Health Information Exchange Measure, or HIE. This is perhaps the most difficult. This measure has three components: sending, receiving, and incorporating. Sending means that you are using the EHR to send referrals or summary of care documents through your EHR via direct address. Receiving is accepting the summary of care document from other providers, again through the direct address, for any patient that has transitioned care or is newly referred patient. Incorporating means that you're including those summary of cares into the patient's medical record and that you're performing a clinical reconciliation. Many of you are familiar with medication reconciliation measure, but this takes it a step farther to ensure that you are also reconciling allergies as well as the problem list. It's important to mention that there are still applicable exclusions for this measure regardless of your program. If you are a provider that refers less than 100 times in a 90-day period, or if you're a provider that e-prescribes less than 100 times in a 90-day period, you are eligible for an exclusion in this category. For MIPS, this category will then be reweighted. For Medicaid, it will just be an exclusion. As you work through this measure, you need to verify your direct address. In some systems, this may be an add-on feature. There is an additional charge. You need to make sure that you have it, that it is enabled, and that you test it. Larger health systems require that you do a test submission for the direct address in order to refer electronically. Start collecting the direct addresses for the providers that you most frequently refer to and begin attempting to send your referrals this way. You may need to continue for the time being to use your standard workflows while offices are shifting to the use of direct address. All right. Some of the specifics related to MIPS reporting. There are a few opportunities for bonus points in the e-prescribing measure. Query of Prescription Drug Monitoring Program, or PDMP, is worth an additional 5 points. Likewise, the verification of an opioid treatment agreement is worth 5 points. Check with your vendor on these two items. Some systems are already equipped, but many others expect you to enable certain elements for use, or in some cases are adding at a later date. The Patient Access Measure, Provide Patients Electronic Access to Their Health Information, is worth 40% of the total points in PI. So a low score here will have a significant impact on the overall category score. A measure that had gradually become less challenging for providers may now be a bit more difficult. While you are still providing patients access to their medical records, many EHRs have changed the way in which you do this. Knowing these nuances is critical to capturing accurate data. Pulling reports now to be sure that you're getting credit for the work that you're currently doing is very important. For example, some vendors may require that you register for additional programming associated with the access to mobile apps. If you've not done so, you may not be getting credit for this measure. Just as in previous program years, You will also want to make sure that the MIPS providers are closing these notes within 4 business days, and a summary of care document is made available to the patient. The Public Health and Clinical Data Exchange measure includes all that you see listed here. For the immunization registry reporting, make sure that you're signed up with an intent to submit data to this registry. If you're participating in NCHIEA or NC Health Connects or another form of clinical data registry reporting, you will be able to get credit for this as well. For MIPS providers, 1 exclusion plus 1 yes or 2 yes answers will equal the full points for this category. All right, shifting gears a bit now to the Medicaid Meaningful Use program. Clinical decision support is a measure that many of you are familiar with. This remains the same as in years past. But just a reminder, be sure that you verify that all the settings are still enabled in your system, particularly if you've had recent system upgrades. Provide patient electronic access to their health information. This is different from years past. The measure thresholds have increased significantly, and the patient education measure is now part of patient access. In many systems, this has meant a new workflow for providing education. If you're still adding education to the patient chart or patient portal, just as you have previously, but your stage 3 reports are not reflecting that you're providing that education, you'll want to follow up with your vendor to verify that you have the proper workflow. This might even be an add-on feature for some of your systems. So follow up with this as soon as possible. Next, let's look at coordination. Coordination of care through patient engagement. This is the old VDT measure. It's basically the same, but the measure will now incorporate the number of patients that access their health information through an app or mobile device as well. The threshold remains 5%, but as you've seen in the past, this can sometimes be a challenge since we're relying on patients to log in to look at their portal. And the third part of this measure is new. The patient-generated health data could be many different things. This may include, but it is not limited to, nutrition logs, blood pressure logs, medical device data, information about the patient's social determinants of health, or even the presence or absence of an advanced directive. Systems will generally have a specific data field for you to enter this information. Find out now where this data field is and be sure to document pertinent information in that data field in order to meet this 5% threshold. Using the CPOE for medication, laboratory, and diagnostic imaging orders is the same as in previous program years, but note that the threshold has increased. So make sure that you're using CPOE for at least 60% of all of your orders. If you are a provider that writes fewer than 100 of these orders, you will be eligible for an exclusion in this measure. Public Health and Clinical Data Registry reporting. As you can see, the Public Health Registry reporting is not an option currently in North Carolina, neither is the syndromic surveillance reporting. If you are signed up with an intent to submit data to the NCIR, and you, for example, report to a clinical data registry, such as the Cancer or Diabetes Registry, or if you're connected with NCHIEA, NC Health Connects, or if you're connected to NCHIEA via CCHIE, then you can receive full credit for this as well. All right, helpful tips. I can't stress it enough. If you're planning to attest for either program, get your 2015 Certified Electronic Health Records. If you're unsure, or if you have a planned upgrade, try to expedite that and follow up with your vendor as soon as possible. Run your reports as soon as they are available. Determine which areas need your attention first. If you're a MIPS provider, you may need to wait on your dashboard to update, but as soon as that is made available, make sure that you're running a year-to-date report to determine which areas or which measures you need to focus on. If you're a meaningful use provider, please make sure that you're pulling stage 3 reports. Access your EHR specific workflows. So many of you have wiki pages or help areas for your EHR, and you can pull from there the specific workflows for stage 3 measures or non-transition measures for MIPS. Do that and make sure that you are making all necessary changes. Remember that a 90-day minimum reporting period is required for MIPS and meaningful use. So if you need to work out the kinks of your workflows, you want to get started as soon as possible so that you can have a solid 90 days to report on. Schedule time to meet with your consultant regularly. They can help you with workflows, pulling reports, etc. PI is tough this year, so get started now. All right, now we're going to open it up to any questions. If you want to put them in the chat, you're welcome to, or if you're welcome to speak up if anybody has any questions or anything you'd want to discuss. Okay, so if there are no specific questions on any of the measures or objectives that we just went through, I'm going to make sure that the slides are sent out for everyone. There will also be a recorded version of this webinar if you want other support staff to view. I just want to thank everybody for attending, and be sure you follow up with your consultant soon.